Good morning friends. Today we will be talking about adult onset flat foot. It is also called as a fallen arch or a flat arch. So what is a flat arch? A normal foot should be a shape like this. If this arch is not there and it flattens down, it is called as a flat foot. So why does a arch disappears with time in an adult individual? So there are many reasons and many theories. So there are static stabilizers and there are dynamic stabilizers of the foot arch. The most important dynamic stabilizer is the tibialis posterior tendon. Tibialis posterior tendon is a tendon which is found just posterior to the medial malleolus, and it is the only tendon which rounds about the medial malleolus at an angle of 90 degrees. And just after the bend, about 1 centimeter to 2 to 2.5 centimeter from the medial malleolus, there is an avascular zone or a zone of decreased vascularity where there is a high propensity of the tendon being degenerated, and there are high possibilities of tear in that particular watershed zone. So when there is an injury in that particular area or that watershed zone, the dynamic stabilizers weaken and there is a chance that foot may go into a flat foot type of scenario. Now tibialis posterior tendon is a tendon which gives multiple slips to all the bones in the foot. So there are two slips, the anterior slip and the posterior slip. The anterior slip goes to the medial sided bones, the larger bones, and the smaller posterior slip will go to the middle and the lateral cuneiform and even the metatarsals. Now this is about the dynamic stabilizer. Now come the static stabilizer. The most common static stabilizer, the most important static stabilizer is the spring ligament. Now what's the spring ligament? Spring ligament is a broad structure and it forms the base of the arch. So what? It goes from the sustentaculum of the calcaneum to the navicular, and it has got two bands. One is an anteromedial band and one is an inferior band, and it forms a support to the arch. So if your arch is like that, the spring ligament will form a support at the top edge of the arch, and slowly with increased deformity, the spring ligament is a soft structure and it has got high propensity to stretching out or to weaken with time. Now adult onset flat foot usually starts after about 30 to 40 years of age, and there are some high risk individuals in which the risk of this particular disease is more. So what are those high risk groups? One is the patients who are obese, patients who are suffering from comorbid illness like diabetes and hypertension. Also patients having diseases like seronegative arthropathy and rheumatoid arthritis can also have high risk of developing a flat foot. Also, we have seen that those patients who have injury to the foot and any surgeries to the foot are at a high risk of developing this particular disorders. Occasionally, we have also seen that varus deformity of the knee, which is the osteoarthritis, which is very common, also predisposes to a flat foot deformity, because your knees go into a varus and there is a compensatory valgus in your foot. So occasionally a knee problem can also give rise to a flat foot deformity. And now the very important reason, occasionally if you give any injections, any steroid injections just below the medial malleolus, that can also lead to weakening of the tibialis posterior tendon and an acquired form of a acquired flat foot deformity. So that is also a thing that you should remember. Now as I told you, there is a particular sequence of this deformity which is progressing. So usually, as I told you, the deformity starts either from the spring ligamentous complex, which is a static stabilizer, or from a tibialis posterior dysfunction, and it slowly will increase. So initially it's predominantly a hindfoot deformity, and slowly when it progresses it will lead to stretching of the spring ligament, it will lead to a forefoot abduction deformity and the rotation deformity of the foot as well. And slowly when the problem develops, there will be a lengthening of the deltoid, that is the medial collateral ligaments of the ankle as well. And slowly there will be a heel valgus which will develop. Now as the heel valgus will develop, there will be a conversion of the posterior cord, that is the tendoachilles, from to a everter. So if there is a heel valgus, the tendoachilles will act in opposite direction and will cause a further increase in the deformity. So it's a progressive deformity and it progresses slowly. Same, there will be a forefoot abduction, and so there are two tests, there are two clinical tests that we do to evaluate this particular condition. One is we do a prone inspection test, and you can see a increased toe sign. So that is a finding which is suggestive of increased abduction of the forefoot, and therefore more toes will be visible on the posterior inspection. A second very important dynamic test to be done is a heel raise test. So if the patient is able to stand on its heel, it is suggestive of the phenomenon that the tibialis posterior tendon is intact and is working. Because if the tendon is torn or if severely damaged, the patient will not be able to stand on his forefoot. So that is very important concept. Now regarding the pain, usually the pain starts from the medial aspect and it is just below the medial malleolus. And in the initial phase, the pain is due to swelling and synovitis in the tibialis posterior tendon per se. Slowly, as the disease advances and the patient's foot goes from an arch to a flat to a heel valgus to a forefoot abduction, there will be a lateral impingement and the fibula will be impinging on the calcaneum, and that will start causing sinus tarsi pain on the lateral side as well. So it starts from the medial side but slowly involves whole of the foot, and slowly the whole of the biomechanics of the foot gets distorted. Now there are numerous staging which are described. The most common staging that we see is the Johnson's and Storm staging. In usually early stages, there is only the swelling and a synovial inflammation in the tibialis posterior tendon per se. And in this particular stage, it can be addressed easily with conservative management. So in a conservative management, we can give rest to the patient for about 6 to 8 weeks. You can give a short duration of a cast or immobilization in form of any brace. Occasionally, you may like to cast the patient for some time. You will also like to do NSAIDs for some duration. And if it is not better, it's a small surgery. You just explore the tibialis posterior tendon, debride it, remove the synovitis, and debride the dead portion of the tendon, and that usually will suffice. But if the disease is advanced, say that is a stage 2 disease and it's a flexible kind of a flat foot, then you may need to do some extra for the patient. So in the stage 2, if you want to do a conservative treatment, you can do a hinge orthosis to the patient, and you can also do some kind of a arch. So you can give either a medial arch support to the patient and medial and arch which is covering both the medial part of the foot as well as the heel. And if it is not improved with these orthosis, then you can do a surgical procedure which is called as an FDL transfer, in which the FDL tendon, which is passing just posterior to the tibialis posterior tendon, is cut and it is rerouted through the navicular bone. So it forms a dynamic sling for the arch. The important part is, as there is a intersection at the master knot of Henry between the FHN and FDL, usually it does not cause much weakness if you even remove the FDL at the distal end. Also, it is recommended that you do a procedure which is called as a medial displacement calcaneal osteotomy. The procedure was described and propagated by Myersons, in which you approach from the lateral side, do a calcaneal osteotomy, shift the portion medially. So you do a medial displacement of the calcaneum heel. You can do up to a centimeter of the medial displacement, and you fix it up with screws, and that will cure or improve the heel valgus, and will improve the overall biomechanics of the foot, and will make your repair or your tendon transfer of the FDL more secure. In occasional circumstances, you might need to do a lateral column lengthening, and the best technique to do is for a lateral column lengthening is the Evans procedure. That is, you do a distal calcaneal osteotomy, opening wedge, and you increase the length of the distal calcaneum, and that will actually make your distal column long and will help to make the arch on the medial aspect. If the disease is increased beyond this level, that is stage 3, then you may consider doing subtalar arthrodesis with correction. So whenever I do a subtalar arthrodesis, I also do a medial calcaneal osteotomy to actually correct the heel valgus to protect the arthrodesis as well. There is a stage 4 also described, in which the disease progresses to the tibiotalar part, and in this particular cases you might want to add a pantalar kind of arthrodesis along with the corrective deformity. So friends, if you have any questions, you can write it on the comment box, and we'll be very happy to help you out in this particular topic. Thank you.